Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, as part of a periodic series on overdose and the pandemic, Dr. Brendan Saloner, a Bloomberg Associate Professor of American Health, speaks with Professor Chinazo Cunningham of Montefiore Medical Center. They discuss the challenges of providing patient-centered treatment for opioid use disorder in the midst of the COVID-19 pandemic. Let's listen.
We're joined today by Dr. Chinazo Cunningham. Dr. Cunningham is a professor of medicine at the Albert Einstein College of Medicine and the associate chief in the Division of General Internal Medicine at Montefiore Medical Center. She works at the forefront of providing care, developing programs, and conducting research focused on marginalized populations, including people who use drugs with or at risk for HIV infection. So Dr. Cunningham, welcome.
Thank you so much.
You're both a prolific researcher and a practicing doctor of addiction medicine. Can you tell us about the population that you treat for substance use disorders at Montefiore?
Sure. So I am a primary care physician, and I work in a federally qualified health center in the South Bronx. I've been there for 22 years, and I treat people really from the surrounding community, and that community has really been devastated by addiction for decades. And so most of my patients are poor. Most of them are Black or Hispanic, and most of them have opioid use disorder, with also a substantial proportion also with cocaine use disorder.
So we sometimes talk about low barrier treatment. What are some of the ways that your practice makes treatment easier to access for these people?
Yeah, so since we initially developed our buprenorphine treatment program, we certainly did that with an eye towards trying to really improve access to care for people. And so the way in which we've structured care definitely addresses that. So for example, we have a buprenorphine coordinator who is either a pharmacist or a nurse, like a nurse care manager, who is a point person, so that people sort of don't bounce around the system trying to figure out who is a buprenorphine prescriber. So they go to one person. It's a central process. And that person, it really has availability often within the same day to reach out to the patient, talk to them about what treatment would be like, make sure that they have, some of the most basic things that would make them eligible for treatment, such like insurance. I mean, we take most insurance plans, nearly all of them, except for maybe like one. We want to make sure that, for example, they're not on high doses of methadone or other things that might make treatment with buprenorphine just very challenging. And so once we do that, we then schedule them for an appointment, usually within 48 hours. And so, and that's a very different process than what it looks like for sort of other people who are seeking treatment for the first time in our clinic, who are just seeking it for primary care. And so the waits for other people might be in the range from 2 weeks to 6 weeks in order to get a primary care appointment, whereas for people who have opioid use disorder, that would happen in like 2 days. So that's a huge difference. And again, we've really worked with our leadership in our clinic, and we really developed the program with an eye towards being able to get people access to care when they need it.
Why is it so important that people not wait 2 weeks or 4 weeks, to get into treatment?
But we want to, take advantage of the time when people are ready and interested in treatment. We want to grab them, right, during that time. We've definitely seen that if we wait and we have a lot of barriers that people have to overcome, then they can lose interest. And that's the time when they certainly could be at risk for opioid overdose deaths. So as soon as they, make themselves interested, we really want to jump on that opportunity and link them to care.
Great. And you were talking just a moment ago about buprenorphine. Buprenorphine, of course, is one of the 3 FDA-approved medications to treat opioid addiction. And I wonder if you could just say a little bit about why getting medications is so important for patients who have opioid use disorder.
Right. Well, medications are life-saving. I mean, that's the simple answer, right? We know that medications reduce the risk of overdose death by at least 50%. And so medication is treatment. We also are fortunate at Montefiore. We have 5 methadone programs. And actually, one of the methadone programs is literally across the street from my clinic. And so we also coordinate with them and make sure that patients have the right treatment that matches their needs. And so that's really a big plus, that if people, if methadone is really a better treatment for the patient, we can literally walk them across the street, or vice versa. If someone shows up to our methadone program and buprenorphine is a better treatment option, they can also walk them across the street. So it's really wonderful to have, to be able to provide options to our patients and to get the best fit for them.
Great. So practicing in New York City, your patients were amongst those most immediately in peril when COVID cases started to rise last spring. So tell me a little bit about how your clinic adapted to the pandemic.
So I would say in the Bronx, we were in the epicenter of the epicenter. I personally was deployed to provide treatment in our hospital in March, which was at the really point of the surge of COVID. It was really incredibly overwhelming. The whole city of New York shut down. The entire healthcare system changed on the dime. And many of us who were buprenorphine providers were deployed to work in the hospital. Mm-hmm. So I would say what we did is we really worked as a team of providers. So we have about 50 providers who provide buprenorphine treatment in 7 different clinics. And while people were being deployed, here and there, it was really important to have very clear leadership in terms of the buprenorphine treatment program. And so one of my colleagues, Dr. Tiffany Liu, really sort of stepped to the forefront and organized us so that we would ensure that our patients continue to have access to treatment. And so what that looked like was that we met weekly as a team as things were changing so quickly in terms of the policies and regulations around treatment, to make sure that we were on the same page, and to make sure that we were falling within the regulations. We offered only telehealth visits. We provided buprenorphine prescriptions for a much longer period of time. So we gave people 30 days worth easily. And for many patients, we gave them refills. We worked with pharmacies to ensure that they would have access to their medications. We also mailed medications. We mailed naloxone kits to patients, or worked again with pharmacies to have the naloxone kits available when they picked it up. We stopped doing urine drug testing. So we really totally changed the way that we provided treatment. And what's interesting is when we've looked at our sort of preliminary evaluation, and we found that the linkage to care rate during COVID was actually higher than than pre-COVID. And so of those people who sought buprenorphine treatment, 2/3 of them ended up being linked to treatment, as compared to 50% of people pre-COVID. So that's an interesting finding, and I think a lot of that has to do with how we've changed and how the requirements for treatment really sort of changed. But we are looking further into that so that we can learn a little bit more, and so we can continue to make sure that we can really link people to care as best as possible.
Yeah, really interesting. And you talked about the telehealth, and I want to dig into that just a little bit more. So how is telehealth working for your patients? And what have you learned about, how to make it accessible to people who may not have been on online platforms before the pandemic?
Right. So that's definitely challenging. So we take care of patients who are homeless and who have changing phone numbers if they have phones, and certainly most of them don't have internet access or data. And that's been really challenging. I mean, I don't have the answer. I mean, for a lot of our patients, when we talk about telehealth visits, the healthcare system encourages us to do video visits, which require internet access and data. Right. And so for a lot of our patients, that's not possible, and we don't care. We will do a phone visit. I've had patients actually seek me out in the park while I'm walking to work because they don't have a phone and they know my schedule. And I have done visits in the park and then provided medications afterwards. So any way we can work around it, we have tried to do that. It still is a challenge, and there's certainly a divide when it comes to technology. Yeah. But we will do anything we can.
Yeah. And now to zoom out a little bit, I mean, one of the troubling things we're seeing nationally is a sharp increase in overdose deaths during the pandemic. What do you think is going on, and what do you think we still need to understand about what's going on?
Yeah, so I don't know that we know what's going on. I think there's still a lot that we need to learn about how opioid use disorder and other substance use disorders, how they've sort of evolved during this pandemic. My sense is probably that treatment was limited, and so that certainly may have affected people's ability to access their medication. And if they couldn't access their medication, they would go into opioid withdrawal. Then they would, use whatever opioid they could get their hands on, which could contain fentanyl. Mm-hmm. That's one big way. I think people probably also lost some of their tolerance just because the market's probably shifted and their access to drugs probably changed. And if they had a decrease in their tolerance, then they would be at risk for overdose if they use the same amount that they would normally use. That's another reason. And then I think a third reason is certainly with social distancing, people are more likely to be alone. And if they're using alone and they overdose and there's nobody there to, help, reverse their overdose. So, I think those are all definitely possibilities. I don't know that we know, what the cause is, but certainly it's important to find out because the pandemic's not over, and it's not even anywhere close to being over. And, there will be more pandemics in our lifetime. So I think we do need to learn from this and figure out how to try and prevent overdose deaths as much as possible.
One final question. With the incoming Biden administration, what do you see as the most urgently needed changes in federal policy to treat addiction and prevent overdose?
Oh, we need, I have a wish list. We need to change policies around widespread to make sure that opioid use disorder treatment is woven into mainstream healthcare. We cannot have our treatment system segregated as it has been for decades. And so how do we get hospitals, healthcare providers to provide treatment? We have to incentivize them or penalize them if they don't. And so, incentives that we use across the whole healthcare system for other conditions like heart failure and certain infections. We know how to do that. We just need to insert opioid use disorder or substance use disorders into that as well. And so once systems are incentivized to provide treatment, they will do it in 10 minutes. But to this point, we've been sort of relying on the goodwill of individual providers, and that will get us only so far.
Dr. Chinazo Cunningham, thank you so much for coming on the podcast.
Thank you. Thank you for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.